this is a very unfortunate young 37-year-old patient who presented for 2 weeks with abdominal pain and nausea. So I'm just going to scroll through. First, show the CT. Anyone has any thoughts? Go back.
I was seeing a bunch of nodular masses in the pancreas and the omentum.
Okay.
And maybe a dominant mass in the pancreas, like cystic and solid.
Okay,
and
so
looks unusual for adeno. So I'm thinking of things like that. And actually, is it growing in the duct?
That's a great thought. So also the other thing is there were lymph nodes, right?
Okay. Yeah, so we can think about lymphoma and other metastatic.
Okay, so I forgot, I missed giving one history, which the patient had history of Hashimoto's thyroiditis. But anyway, so this is the coronal. So anyone, so you were thinking of, you said either lymphoma, which is one of the thoughts that we had. And the other thing based on the CT we thought was, can it be some unusual, acinar cell type of carcinoma?
Yeah, or a neuroendocrine sometimes can grow along like that.
Or a neuroendocrine tumor, exactly. Yeah. Exactly. So his CA 99 was elevated. His CEA was normal. So then he had an MR. And of course, he had ascites. And he had an FNA, so I can tell you what that turned out to be later. So this is the axial.
Anyone else have any thoughts?
This is the coronal.
To me, it still looks very like papillary fronds within cystic structures. So I'm still thinking maybe some like variant of an IPMN with like very extensive polypoid.
So that's exactly what this turned out to be. This turned out to be like the most gigantic IPMN I have seen. And you can see that even here, there are actually soft tissue nodules within the, oh, sorry, going the wrong way. See this? So there are actual nodules seen throughout. So what we couldn't see very well here, you can see it a lot better here, that it's actually the duct that is dilated. And all these were soft tissue fronds growing within the duct and around the duct. Again, you can see that here.
And what was the age again? I mean, that's the sad, really unusual part too, right? Like
37.
Young, yeah. So IPMN is not just a disease of the elderly.
Yes, and the only thing that none of the people in our group had seen the lymph nodes so bright, and I mean we didn't know whether it is because it was a mucinous tumor. That was Gitanjali's thought, is it because it's a mucinous tumor? Is that why the nodules are bright too? But we were not really sure why that happened. And
yeah, there's also like a colloid cancer that you can develop in IPMNs, and sometimes those can be very T2.
Right. So, but this was, I was going to share a PowerPoint slide in a second. So just one other history so this patient 2 years back had back pain. He used to live out of town and he had a spine MR done. And this is, you guys can still see my screen, right?
Yes. Yeah.
So this was a spine MR done at that time. And you can actually see the dilated duct with this big cystic area.
Oh, wow.
So apparently it was also reported, but nothing got done. There was no follow-up. And so potentially he could have had a pancreatectomy at that time also. So it's really unfortunate on many, many different, levels as to what happened to him. So it did turn out to be a IPM, and I just wanted to quickly show. So I asked our pathologist to share some slides. And so this is what she sent. This is from this patient's FNAC. And you guys can still see this?
Yes, it's beautiful.
Right. So this is the papillary with the fibrovascular cores, and the mucinous part is seen better here with the goblet cells. So she just made this for me. I said I'm showing this case at the conference. So with the goblet cells, and I found a very nice article where they talk about these 3 types of cells, and one of them that you were talking about was, so you have the gastric type epithelium, you have the intestinal type epithelium, and the pancreaticobiliary type IPMN, which is what this one turned out to be. But I tried looking for, I did a search on metastatic IPMN, and I just wasn't able to find anything other than that they can metastasize to lymph nodes. I have not seen this. I mean, the rest of the things, in fact, he also has pulmonary nodules and supraclavicular lymph nodes. So
yeah, that's really interesting about the that it turned out to be pancreaticobiliary type, because those lymph nodes really look mucinous. So that's really unusual. And then I guess the supraclavicular nodes are probably from the lymphatic drainage through the thoracic duct and to like the Virchow's node.
Right. Okay, so I can't find my Zoom to
Sorry,
stop
can I ask a
sharing.
question?
Yes.
Can I hi, it's Teresa at Mayo, Arizona. I was curious as to the comment on the history of Hashimoto's thyroiditis.
So that turned out to be kind of a red herring, because
Okay.
we thought that he might have, lymphoma of the pancreas.
Okay.
When we got that history and on CT it looked so weird, we thought he might have lymphoma of the pancreas.
Thanks.
Quick related question. If you have Hashimoto's, does that predispose you to getting lymphoma anywhere, or only like mainly in the thyroid?
It was actually mainly in the thyroid,
Okay.
but we were just trying to, since we weren't really sure what was going on.
Yeah.
We were just trying to put 2 and 2 together.
Yeah. Very interesting. Thank you.
Okay, I'm going to stop sharing.
Okay, Ben.
Hi, everyone. I have a very interesting case that I'd love to share. So this is a female patient in her 60s or 70s, and I have 4 examinations that are open here. One is from 12 to 15 years ago. The second one is from 5 to 8 years ago. The third one is from 2 to 4 years ago, and the last one is a little bit more recent. So there were a couple of interesting findings on this patient, and it's not a diagnostic dilemma, but it's a very good example of some of the things that we've talked about earlier in the year on this conference. So when I came across it, I wanted to share it with the group. So I'm just gonna scroll through this examination here. So this was the oldest exam. The follow-up examination is here. And I draw your attention specifically to the pancreas and the kidneys for these 2 exams. Then the follow-up examination would be here. And again, you can see the pancreas has become tiny. Anybody have any thoughts as to what this entity is?
So the renal hypointensities reminded me of IgG4.
That's exactly it.
Pancreas
Yeah.
usually gets enlarged and sausagey, but it looks like it's withering
So
away.
this
And I don't know
was-
if they're on
right.
steroids or what.
So this was exactly correct, and this was kind of initially identified as a sausage-shaped pancreas. And if I can convince you, the lobulations are not really there, and it did over time kind of wither away, and you can barely see it on the more recent exam. And there's also this tubulointerstitial nephritis. On the first exam, the kidneys look pristine, and they're fine. And then you see all these defects that over time develop in the kidneys. So I thought that was a very good example
Were they on
of this
steroids this
entity.
whole time, or were they being treated for it? Or
They were given steroids, but unfortunately it did progress. And this was over a course of 15 to 18 years. I was told not to like give exact dates, but this was over a very long period of time. And I was lucky enough that I was able to see all of these exams because we have them. We've been following this patient for a while at our institution. The only other thing, and this was a learning point for me, is that there's obviously a lot of other manifestations of IgG4 disease, but one of the manifestations is these ground glass and consolidated opacities in the lungs. And if I can convince you, this patient has had that as well. And it's also this upper lobe opacity has been getting worse over time. It wasn't really there on the initial exam, and it's developed and is kind of progressing.
wow,
So then the
that's really
kidney
dramatic.
problems, Aarti, I have a question. So the kidney issues are not vascular?
I was actually going to ask Ben or EM, whoever that is that wrote into the chat, if they could expand upon the kidney issues. I somehow thought that the kidneys were these lymphoplasmacytic infiltrates, like IgG4 deposits.
I think they
I've seen like
get stuck.
rounded little hypoenhancing masses in the kidneys. But what is the nephritis part, or interstitial nephritis part? Does anyone
What I've
know?
read also,
Atrophy of the kidney also, which is why I thought it was some vasculitis.
Which makes sense because, well, in the pancreas, you definitely get a vasculitis. You get obliteration of your veins and a lot of like perivenular inflammation. So maybe that's what's happening there.
that could be the when I read about this entity, what I read was that it has to do with the deposits getting stuck in the kidney and over time causing damage, which is basically what Aarti said.
Yeah, so maybe it's all those IgG4 cells kind of making little pseudomasses, and then also maybe a vascular occlusion as well. Okay, thank you, Ben. Victoria?
Hi, I'm sorry. It always takes me a minute to unmute. Okay. Me?
Yes.
Okay. So, so these are like just several interesting cases. This was a young woman who had Roux-en-Y gastric bypass and just was sick afterwards. And this is something that I've never seen before, this case. And that is pneumatosis of the esophagus. You can see that the esophagus dilated, filled with debris, and there's clearly pneumatosis. We'll look at the.
Yeah, Victoria, why is that we don't normally see pneumatosis of the esophagus?
I don't know. I guess the ischemia. I honestly don't know. I was thinking about that. Is that the ischemia is less likely? I don't know. I mean, but I have you seen it? Like this for me, this is the first time.
No, I've never seen it. It basically perforates before it becomes ischemic for some reason.
So, and interestingly, that this is confirmed. They went to surgery and this was resected, and she did have ischemic esophagus, as she had ischemic, the gastric remnant, and she had small bowel ischemia. So all of this is from small bowel obstruction, just leading to, necrotic appearance. But I actually don't know why esophagus doesn't get, maybe because people vomit, because the pressure goes up, maybe that's the reason. Because there's always relief of the pressure. And I don't know why she didn't vomit. Maybe that's the reason. Alternatively, this is just kind of dissection. We could say that this was dissection of the air from the necrotic stomach, but part of the esophagus was resected, and on path was, was ischemic. So anyway, so I don't have a good answer, but if somebody has better ideas, um, happy to hear them. But anyway, so this was ischemic esophagus, path proven.
And sorry, what was causing the whole thing? Like,
Oh, so she had surgery. She had gastric bypass, and then she was obstructed. So you can see that she has some small bowel ischemia.
but it also looks like afferent loop syndrome, like the excluded stomach was super dilated, or although maybe it was backing up into
It
the
was all backing up. She had distal obstruction. I don't know. I don't remember what she
exactly
was
why.
obstructed from, but she was obstructed, and everything was just obstructed distal. It was this obstruction distal to the jejunal. So everything was dilated. So crazy case. All right. So the next case is more of a kind of, the finding was not described, was missed. So this was a case. The liver was reported as, hepatobiliary area was reported as normal. Any thoughts?
Looks like focal buildup in the right lobe more than, and like I don't see the bile ducts in the left at all.
Right. So, the right posterior duct is quite different from the rest of the biliary tree. And sorry. When you go to the hepatobiliary phase images, you can see, perhaps subtly, but you can see that this corresponding parenchyma enhances slightly less. And notice that there's normal excretion of bile or eovist into the anterior ducts, into the left ducts, but the right-sided ducts are not dilated. Are not opacified.
Did they have a recent cholecystectomy?
They sure did.
And an aberrant right posterior duct that was clipped?
Yeah, so this was actually exactly that. This was clipped, and they knew it. They knew this happened. If you go back to MR, this MR was shortly after surgery. It was a difficult cholecystectomy for reasons that I don't remember what, but that's how it was described: difficult cholecystectomy, and you can see that the duct was slightly dilated then, but it's more dilated now, and I don't think this was done with eovist. Oh, no, it was. And you can see at that time the parenchyma was still functioning okay. So over time, this this parenchyma is gonna atrophy a little bit. I've seen cases where eventually it stabilizes, but I've also seen cases where it just continues to shrink down. Anyway, so it's not like a miss that's detrimental to the patient, thankfully, but it is an important kind of finding to make.
Yeah, I've seen cases like this, and people ask me like, well, what's the treatment? And basically they don't treat it. They don't go try to open it up. They just kind of let the posterior sector atrophy.
Yeah.
And it would be kind of like the argument for doing an MRCP on everybody before they get a cholecystectomy, but we can't, that's not practical. So
Right.
It's just kind of like the surgeons have to be really aware, like if there's some other large duct coming out of the liver, it may not be a duct of Luschka, might be an aberrant right posterior duct, and trying not to clip that.
They they knew that they were clipping it. Again, it was described as difficult cholecystectomy. They were aware that they clipped it during the surgery. They actually called in, our transplant surgeon to see if, if she can reimplant the duct, and she assessed it as being too small and just let it go. But this is, but detection of asymmetric biliary dilatation is important, because sometimes that's how early cholangio will present, just as this is asymmetrically dilated duct. So anyway, in this last case is kind of interesting and almost a consult case. This is a young man who was diagnosed with, this was angiosarcoma of the spleen, not that long ago. And at the time he was, the spleen was resected, and he was remaining stable on CTs, and now he got an MR. And we see these lesions in the liver. Initially, they look like they don't quite enhance on the, this is portal venous phase. But when we go to the delayed phase, give me 1 second. So you can see that a lot of them kind of no longer visible. They almost equalize. So they're not really cysts. And this is just to compare. You can see them very, very nicely early on, and then later on, you don't see them, or don't see them nearly as well. On the diffusion, one of them restricts, but it's also a one that is very, very bright on T1. So it could be something hemorrhagic. Hold on, PAX is a little slow, so bear with me.
I'm sorry, what was the history? It was
History
diffuse liver disease?
splenic angiosarcoma.
Okay, sarcoma.
Hey, Victoria, you know how your original splenic angiosarc was multifocal in the spleen? Does that mean, do you know if that means a worse prognosis, or does that mean intrasplenic mets, or does that mean anything?
I don't know. I remember Kuki, when we had a splenic angiosarcoma case a few months ago, Kuki mentioned that these patients do very, very bad. She said that there's just a bad disease to have. I remember she made a point that this, so I presume that the prognosis is so bad, it's probably hard to gradate, the badness.
Do you have the T2 on this case?
I do, and it's not very helpful. The answer is I don't know what these are. It's more of a, do you have any better ideas than what I came up with? So you don't really see them.
I'm concerned about that DWI.
I'm concerned.
Me too.
Right. So I'm concerned. Now, check this out. She also, look at the bones. So these are all abnormal bones, which on contrast, you can see that. So now this person has a lot of mets. And then this last point is kind of very unusual. Look at the split of the hepatic capsule. See that? And it's real. It's not an artifact. So you see this kind of diffuse hyperenhancement of the capsule.
Oh, wow. So are you thinking peritoneal, the entire peritoneal lining is involved?
Looks like the peritoneal sidewalls are doing the same thing.
So, right. So I think that, well, I'm pretty sure, I have no other explanation, but to say that the capsule is involved by tumor, right? You see this. And if you go, and interestingly, when you look at the diffusion, you see it, except for when I first look at the diffusion, I dismissed it as, sometimes at the edge we see some, like here, we see a funny signal. So, but I think it must be real, because it's a real, real studying of the capsule. And you can see that, perineum. So it's a very unusual case in the sense that clearly there's a lot of disease. There's bone mets, which they suspected by the fact that alk-Phos was elevated, but they were never able to demonstrate the mets because the recent CT was normal. Right there. So you can see that the CT is normal. So so it's a weird case. I still don't know what these lesions are in the liver. I mean, I suspect that there are some unusual mets, but they're so unusual that, sorry, I just don't know why they behave the way they do. If you look at the subtraction images, they don't enhance. They really don't look like they enhance. So I just don't know how to explain the liver behavior.
I feel like the enhancement aspect is tricky. And to me, it seems like neuroendocrine-esque, where if I see it on diffusion, I'm still really concerned, regardless of not being able to see it on T2 or post contrast. Like it's just blending in.
No, but look, these are actually, look at that, no enhancement. And only this one was showing restricted diffusion, and that's the one that had very bright signal in T1. So potentially this restricted diffusion, because it's, you know, potential. At first I thought maybe this is just a weird hemorrhagic cyst, but then, you know, they look very different on the delayed. I don't know. So I mean, they're probably Mets, you know, very high chance that they're Mets, but it's a very unusual appearance, and I didn't have a good explanation.
Yeah, I don't know, maybe just super necrotic, but you said they were new, right?
Well, he never had an MR, and on CT,
Oh, I see.
really there's nothing, you know, but CT, I would hesitate to say that they're definitely new, because, you know, CT may not necessarily detect such tiny things. But you can see that this thickening of the peritoneum and the capsule was not really apparent on the CT from early January, so like 2 months ago. Right, like look, this was pretty clean looking, and I would expect that we would see something like here. Just you know, so put it side by side there, right? So this kind of blunting, I would assume we would see if it was present, but it's not. It's pretty clean. So I presume that this capsular involvement is new. Anyway, it's a very unusual, weird case. I assume that PET scan will be positive, since these are very aggressive tumors, but I actually don't know if they tend to be positive or not. Anyway, that's all I got.
Okay, anyone else? I'm going to share my screen. Okay, this one is also courtesy of my fellow Omar, who hopefully one day will present his amazing cases at this conference. But okay, this patient is a young patient, and I'm not going to tell you more about the history, but I'll show you the sagittal first. And we want to focus on the reproductive organs here. Young female. So this slice, I think, has some helpful information. So we've got bladder and urethra. Mm-hmm.
Oh, there's no uterus.
She's missing some stuff.
Yes, exactly. So bladder, urethra. So female urethra is only about 4 centimeters long, and here we see it nicely. Rectal, so this is anus and rectum. And then here, this is the bottom half of the vagina. And then we don't see the top half, and we don't see a uterus. And then if I go to the axial, we can see this is the right ovary, this is the left ovary. Scrolling down, there's the urethra, the vagina, which then disappears. We have no uterus.
And of course, there's an eponym.
Yeah.
What are the kidneys like?
We don't have the kidneys here, but that's a good thought, because if you have a uterine abnormality, you have renal agenesis frequently. There's another finding here that's really cool. So this is the uterus, and there's something in front of the uterus on this. Sorry, this is the ovary, and then there's something in front of it over here. And then this is the other ovary, and there's something over here.
Do you have the T1s?
Yep, I can show you the T1 in a sec. So we're just going to show that whatever that thing is has a bright center to it on both sides. Right there, it's kind of got like a little bit of a central linear bright thing. This is the T1. So that structure is right there on the left and right here on the right. Why did you ask for the T1s?
I just wanted to know if there were, I mean, it sounds like it's like congenital absence of the uterus, and there's that eponym that Steve alluded to, which I can't remember, but just making sure it's not like something else.
Yeah, and so one of the things that T1 can tell you, so these are rudimentary horns. So we have like a really nice rudimentary horn on the right, and then another one on the left, and you can even see the rest of the rudimentary horn of the uterus here, and they're just not fused. So they're completely separated from each other. They never fused, and they never became like the uterus, and therefore the cervix and the top of the vagina also did not develop. And one thing we want to look for is to see if we think there's functional endometrium. And in this case, we thought there was functional endometrium because of this bright signal here that looks like a normal endometrium. But one thing you can look also for on T1 pre is to see if there's any blood in there, to say like, oh, it's actually making, you know, like menstruating and making blood that's not able to leave because of the lack of development. In this case, we didn't see blood or, you know, trapped blood or from the endometrium, but the patient ended up getting them resected because we thought that this was functional endometrium, and these were rudimentary horns with endometrial tissue. The reason you need to resect them is because that endometrial proliferation over time can lead to malignancy. It can cause pain. It's basically like hematocolpos or hematometros. So yeah, it was just and the eponym, anyone? I know someone out there knows it.
Meyer-Rokitansky.
Yeah, exactly. Meyer-Rokitansky-Kuster-Hauser syndrome. So MRHK.
If you go up a little bit more, are the fallopian tubes there? Like, are those some of the fallopian tubes?
Oh yeah, that's a great.
I think they're supposed to still have them.
They're definitely still supposed to have them. This might be small bowel here. I'm actually not sure.
I was thinking more midline.
Yeah, I think that's small bowel. But in this syndrome, you have normal ovaries and normal fallopian tubes. That's the type A. And type B, you actually also have abnormalities of the ovaries, fallopian tubes, and kidneys. So type A is a little bit less severe, where it's basically just absence of the uterus, and maybe they in the future could get a uterine transplant. That's a possibility in the future, or some people have tried it now. And then also in type B, you get more severe abnormalities, including of the kidneys. So yeah, you can just also call it Mullerian agenesis if you don't want to remember that. And actually, I was trying to figure out why they call it Meyer-Rokitansky-Kuster-Hauser syndrome, because those 4 pathologists lived at different time periods, some of them. So I think whoever finally put it all together gave them each credit, but it's kind of confusing. So, okay. My next case is an ultrasound. So do this. Okay. So this is a young female as well. And this is the lesion I wanted to show you. You can see it's got some echoes in it. And it's got this structure on the side. And maybe even the structure over here on the side. Had some flow, but we thought maybe it was the edge of the ovary, not sure. Other ovary is fine. So what do you guys think about, any thoughts on this? I can also show you a cine and show you this area better. Okay, this is the cine. So you can see there's like a lot of soft tissue and cystic spaces in this part of the this large adnexal cystic lesion, and then there's other kind of like bright echoes in there. Harder to see on the cine, but we saw a lot of little echoes on the still images, and then we see this like solid component here that did have vascularity in it. So what are you guys thinking?
Aarti, is there like a fetus in there?
It was not, and also her pregnancy test was negative. And actually, interestingly, this mass was detected while she was pregnant. And then this is now her postpartum scan and the mass is still there.
Gotcha.
And I can't see the chat. I don't know if anyone's chatting in, but if somebody is, please tell me what they're saying.
I just said it doesn't look good.
Yeah, so I was thinking, all this big, solid, soft tissue component, and just going back to the other images, so the two things I was thinking is is this an epithelial neoplasm with malignant degeneration, or with all these homogeneous echoes, is this an endometrioma with malignant degeneration? Anyone else type anything into the chat?
Borderline tumor.
Okay, good thought. Anyone else? Okay, so
we don't have CT or MR, right?
nothing
we know
else.
This is adnexal in origin. I mean,
yeah, we couldn't find the right ovary. We thought it was adnexal. She was having a lot of pain. It was 10 centimeters. She went to the OR. It was resected, which I think sometimes we would like an MRI, but often if we think that something's like a partially solid ovarian mass, they'll go to the OR.
I mean, other thoughts are infection, and you would know that clinically, or torsed ovary sometimes.
Okay, all great thoughts. So this was a dermoid. And I kind of was kicking myself afterwards, this was a young patient. Why didn't I think about this? But that solid part really threw me off. So I just wanted to review a couple of things about dermoids. So dermoids are mature cystic teratomas. Teratomas have all three layers: ectoderm, mesoderm, and endoderm. And they usually have 2 out of the 3. And actually, pathologically, if the ectoderm predominates, that's when pathologists call it a dermoid. Otherwise, they just call it a mature cystic teratoma. The ectoderm can produce skin and hair. And usually the dermoid cyst has squamous cells lining the cavity, just like our skin cells. And those produce sebum, which is a lipid-rich substance. And that is why we have the perception that there is fat. But it's not really true fat, it's really lipids. And so I was asking my pathologist about fat in a dermoid, and she was like, there's no fat in a dermoid. And so when she thinks of fat, she's thinking about macros, bulk fat from adipocytes. But it's really the sebum that's causing the fatty appearance of these dermoids on CT and MR. And then it also makes keratin, which is rich with protein, and these can actually restrict on diffusion. So that's another thought to be specific sign for a dermoid, which kind of was alarming, interesting to me, because I was thinking if I saw a solid component that was restricting, I would think that would be malignancy, but that the keratin can actually do that. There's less amounts of mesoderm, which can be muscle and fat, and even less endoderm. Basically the imaging is non-specific with virtually limitless combinations, because you can get so many different combinations of cells that are sloughing off and causing debris, hair, skin, teeth, lipid, protein. And so there's so many different ways that it can look. But if you see a very heterogeneous mass in a young patient, think about this. And especially if they're, pretty young. So here's just a couple of the classic findings. And this is basically what I had in my case, which is this Rokitansky nodule. Rokitansky nodule is a bigger conglomerate of soft tissue. It's kind of a combination of rudimentary teeth, hair, fat, but because it's soft tissue, it can enhance. And if there's malignant transformation in a dermoid, it is likely to happen in the Rokitansky nodule. So the pathologists will dissect the nodule extensively to look for any malignant transformation. You can also get the tip of the iceberg sign. This is from a clump of hair, fat, and debris that is reflecting the ultrasound waves back. And all of that complex material is also causing shadowing. This can cause a dermoid to be missed, even a very large dermoid to be missed on ultrasound, because you could mistake it for bowel gas. The dot dash sign is one of the most specific but less common ones, where there's actually appearance of echogenic hair in there. And then often on CT, when we see fat, we feel very confident this is a dermoid. This is all the sebaceous fatty fluid in there. And you can also get a fat fluid level, which is basically some of the fluid and debris layering out with the sebaceous fat on top. Any questions? So I guess in the future, I mean, I still don't know what to do about these Rokitansky nodules because they can harbor malignancy in them. They can enhance, but in the literature, it says like, if you see it infiltrating beyond the lesion, then you're more concerned about malignant transformation. But otherwise you really don't know. And if it's a large enough dermoid, it's probably going to be resected. Okay.
Yeah, I thought about it, about this kind of cyst. Can you hear me?
Yes.
When you said it was very large, and when I saw those solid components, and I have a case with a very large, it was like 30 centimeter. It was all the abdomen was affected in a patient that was actually not young. Was about 50, 55. And she came for a CT for other reasons, and we found this big mass. But then she just underwent surgery and was removed. But apparently she didn't have much symptoms, except mass symptoms, because it was so large. I'm trying to find
probably slowly growing over time.
Yeah. If I find it, I will share that with you.
Okay, great. Yeah, we can, so they can rupture and they can cause a chemical peritonitis, and they can also cause torsion. So usually they'll present somewhat earlier with pain, but yeah, I think we should think about them in, large masses, heterogeneous masses, but maybe a CT, MR and CT definitely probably would have helped. We would have seen some fat in here from all the sebaceous stuff, but they do sometimes go straight to the OR. Nellie, did you have cases, or do you want me to keep going?
I have 2 cases, but you can keep going too if you want. Either way is fine.
Okay, these are pretty quick. This one, this patient was post-op from a surgery, and they had this dilated colon. It was air fluid levels, a distended colon, and then kind of a transition right here. So do you guys think, and somebody has to read the chat to me, do you guys think, what do you guys think about that? Are you concerned about this transition here? I can show you the sagittal as well.
One of the things I think about is sigmoid volvulus, but sometimes.
Yeah, this case wasn't twisted, and then this is the transition here. So pretty long segment, decompressed.
Any radiation?
Yeah, maybe they had radiation or UC.
Nope, radiation, no UC. So this was just a good case of a fake out. We were concerned about this transition. There was upstream dilation. We brought up, could there be a mass here? An obstructing mass. It looks a little shouldered. And we recommended a colonoscopy. And the surgeon said, if there's an obstructing mass, we don't want to do a colonoscopy because we don't want to insufflate the colon and, perforate it. So the other thing that you can do is what they called a GGE. I never knew that was the term for a gastrographic enema, but they're like, do a GGE. I'm like, what is that? So anyway, we did a gastrographic enema and it was completely normal. So that was just decompressed sigmoid colon. I think the rest of it, they had a hip replacement. So I think it was like all the colon was distended from ileus. So, if you can just get those pseudo masses transitions, and you can alleviate, if you can't get a colonoscopy or you don't want to, you're concerned about it, go for a gastrographic enema, and that can answer your question. And then this is my last case. This patient had a prostatectomy. We've shown a couple of cases here where after prostatectomy, there's a little leak. So this patient, we did a urogram, and you could see that there was contrast in the bladder, and then also a tiny little leak posteriorly. This was an outside scan. We didn't go further down than this. So they had a little leak here, but they kept having a dirty UA. So they were concerned about a rectovesicular fistula. And we didn't see contrast going through here. So we said, okay, we don't see it, but we're not going further down. So let's do an MRI. So we did an MRI. And this is our fat saturated T2 weighted image we're looking for a T2 hyperintense tract between that bladder and the rectum. And we saw this little outpoaching, but I did not see a T2 bright tract that was connecting to the rectum. So we said we don't see a definite fistula between the rectum and the bladder. So then we did a.
Did you not use contrast for that?
Oh, we did, but I.
Because the tracts will enhance the same way as like anorectal fistulas, no?
Yes, and again, did not see a enhancing tract, although with the prostatectomy clips, there was like a lot of artifact here as well.
I get it.
So, but did not see a clear enhancing tract. So we then did a gastrograph and enema, and this is the scout film. You always want to scout when you're doing these. And it was the same day as the MRI. So unfortunately, the gadolinium is now being excreted into the bladder. But luckily we have the scout, so we have this baseline. And we filled it up, and we did not see, we saw, let's see where. We saw this, we thought this was the bladder. We thought that was the residual contrast from the gadolinium. In retrospect, there's maybe a tract here.
Close to the rectal wall though, huh?
Yeah, and exactly. It shouldn't go this far back. And so 2 take-home points here. If you're concerned about a fistula, at some point you should put the balloon down so that you can evaluate that area better. And then also, yeah, look very, very carefully even afterwards for these tracts that are getting a little close. We started seeing that thing, but we thought maybe that was still the gadolinium. Here we've got, most of the rectum looked very clean. We still have maybe gadolinium in the bladder. We weren't sure about a fistula. So finally, we did a VCUG. So we put a Foley in, bladder is getting distended. And then we removed the Foley and had them void. And finally, with that extra pressure of the voiding, we now see that tract between the bottom, the cystourethral anastomosis, going posteriorly and into the rectum. So a couple of take-home points. If you're worried about a fistula between the rectum and the bladder, one of the best ways to do it is to fill the bladder because it's a smaller space. And if you do a VCUG, you can actually increase the pressure. So you'll finally prove that fistula. Slightly easier than having it just go up the path of least resistance up the rectum. Yeah, I think that's the main take home here.
I wonder if you could demonstrate it with a CT cystogram.
Yeah, I think we could have done that too.
Doesn't involve voiding, which might have been needed to bring it out though.
Yeah, I think that's a really good thought. And with any of these cystograms, you want to maximally distend the uterus, the bladder as much as possible, as much as the patient can tolerate.
But I always like the cystograms more because you can pressurize the bladder. It's hard to pressurize a colon.
Yes, definitely. Okay, Nelly, you're up.
Okay.
Do you want me to share the cystic teratoma case, or since
sure,
you have it right now?
Yeah, it's just
yeah.
a few images,
Yes.
so that we stay in the same top images. And so we saw here, this was the mass with the calcification. Can you see that?
Yes.
Yes.
Okay. And what was interesting is that we also scanned the patient in a prone position, and you can see that the fat component goes up very, very quickly compared to this image.
Francesca, go down. So when I was reading about it, I heard about something else called these floating nodules, or the meatball sign. And your case actually has that. See those like little nodules in the middle floating?
Yeah, yeah, I was not sure about that. This is kind of an old case.
Yeah, the article I read said like that's one of the most specific signs, but it's rare.
These are other reconstruction that we did, and yeah, it was a cystic mature teratoma, right? Yeah, that's it.
I love the music in the background.
Yeah, I'm sorry.
It's great.
Play.
Francesca lives with a music teacher, so we get
Yeah,
to hear music a
exactly.
lot.
That's why I usually don't talk much because usually she's teaching.
That's awesome.
Thank you.
Thank you, Francesca. Nelly?
Okay. We're gonna. I have a few cases, and I'll just do whatever we have time for. Okay, so we have a phenomenal gynecologist here, and she's like a national expert in endometriosis. So she gets MRIs for patients who are being evaluated in the endometriosis clinic, and this is one of the cases. So let me know what you guys want, and then what sequences you want.
It's along the rectum anterior wall, right? Right there, mushroom sign.
Oh, brilliant, brilliant. Yes. Yes. So
A really nice
here,
example.
yes, that's so. So there's the T2. Let me show you the post. Right there. Right there. So that's right. This is deep infiltrating endometriosis. The colon was resected and was pathology proven. So this is just a really beautiful case of mushroom sign that we see with deep infiltrating endometriosis. And post-con CT can be helpful to kind of pick those spots out, because I think sometimes it can be kind of hard.
Nelly, I
Any
saw a
other
talk
teaching
by
points?
Nicole Heinman saying like
Yeah.
you should describe the depth of invasion of the wall, which I find hard to figure out, but
Yeah.
because that'll like determine if they can do a partial resection of the wall or if they need to do a like partial colectomy. Do you have any tips?
We based on our endometriosis conference, like they want, if it's like 50% involving the wall, then they'll usually resect it. So
Circumferentially.
Oh, the circumferential. So
If it involves
go ahead.
circumferentially more than 50%, then they have to do a bowel resection.
Oh, so it's like, okay, it's like more than 50% circumferentially. Okay, not necessarily how deep it's going.
I think there is a measurement for how deep it is, but if it's less than 50%, they can just do, I don't know what it's called. They don't have to do a full bowel resection, like they don't have to call colorectal surgery in, but they can still, I don't know the term, they can still take it out without doing a bowel resection.
Okay,
this
cool.
came up in one of our conferences recently. So yeah, that distinction is just as Teresa described. She said that if it's 50%, if it's not circumferential involvement, then the gynecologist herself can take care of it.
Got it. Thank you.
This next case, what do you think? We have bilateral renal masses.
Renal or urothelial?
What do you think?
I'm thinking lymphoma.
Maybe
Transitional cell.
that's a really bad upper tract TCC or maybe lymphoma.
Yeah, so this patient, let me show you the PET. Maybe let me pause. And then, okay. So here's the PET. So it's and there's also abnormalities along the cervical chain. Does that change your differential?
What's happening in the bile duct, or is it like what's that green thing in the liver?
Oh, they marked it. So it looks like, I don't know. This is an outside imaging, so I'm actually not sure what's marked over there. That green thing that they highlighted. Maybe it's part of the systemic
Does this
process.
help, Nelly? Because I know lymphoma can be super FDG avid, but I feel like urothelial probably can too.
So this was biopsied, and this is Rosai-Dorfman disease.
Whoa.
So it was a sinus histiocytosis with massive lymphadenopathy, and they usually affects young women, like in the 20s. They get massive cervical adenopathy. They can get fever, malaise, weight loss, night sweats. and they can have intracranial involvement as well. So this patient has cervical involvement as well as bilateral renal involvement. So yeah, it's just, I mean, I think it's tissue's the issue.
Hey, Nelly, can you show us the neck again? And
Yes.
do you think then we should bring that up if they have cervical nodes like that, or like, did they bring this up?
That's a good question. I mean, I like I said, I think it's a different, if we just saw this, you know, with the CT, it's a differential case. I don't think we can confidently call it any, you know, that, but I think important to add in the DDX.
Yeah, I have a couple of cases of Rosai Dorfman of the pancreas now,
Yeah.
but I never feel comfortable bringing it up and prospectively. And both of those we thought were like autoimmune pancreatitis. And after like 5 biopsies, we finally got Rosai Dorfman. So.
Oh, is that right? Oh, that's great. I have one more case, but you know, we're hitting the hour, so I'll just save it until next week.
Okay, sounds good.
That was
Thank you to all our new presenters too. Great to see you guys. See you later.
Thank you.
Thanks, everyone.